Morning, everyone. We're going to allow folks a few seconds to log on here, let people trickle in from the waiting room. All right, I'm going to go ahead and get started with our housekeeping so that we give Dr. Rodin plenty of time to get through her session. Welcome to day 3 of our overdose awareness series. It's hard to believe that we are on to the second half of the series. We have a fantastic lineup for you today. We'll be covering sessions like this morning's withdrawal. We have another one on humanizing through connection. We have a session on the Friends for Life campaign, on adolescent over-the-counter exposures, as well as pediatric fentanyl exposures. So we really hope that you'll join all of our sessions today. We have thoroughly enjoyed all of the audience engagement we've had. You have asked some excellent questions so far, so keep them coming. Just some quick housekeeping to go through before I turn it over to Dr. Rodin. You will be able to get a certificate of attendance for the series, just like every other day, as long as you fill out the day 3 survey. So as a reminder, you do not need to fill this out after every session. You can wait until the end of the day or after the last session that you attend to fill that out. We will have another lunch networking session today, and today we plan to have those breakout rooms self-assign by the audience that you work with or the audience that you're interested in discussing. So we'll have a room dedicated to youth, to older adults, potentially others for LGBTQ2S+, for people who use drugs, refugees, limited English proficiency communities. We're probably going to do some feeling out based on who all joins that networking session, and then we'll create those rooms. So during today's session, please ask your questions in the Q&A box, and then place any other discussion items or introduce yourselves in the chat box. All right, I think we can get going on this session. I'll quickly introduce Dr. Rodin. She is a clinical assistant professor at Washington State University College of Pharmacy and Pharmaceutical Sciences. She splits her time teaching within the curriculum and practicing pharmacy at the WSU Research Clinic for Substance Use Disorders. Dr. Rodin's current research initiatives are centered around public health initiatives, including the prevention and treatment of substance use disorders. Welcome, Dr. Rodin. We're so excited to have you for the 4th time. We always love having her present. She is fantastic. So looking forward to your session today. I'll turn it over to you.
Awesome. Thank you so much, Megan. This is one of my favorite educational series, so I was really excited to present on this topic this year. Like Megan mentioned, if you do have any questions, it's my goal to answer all of them to the best of my ability. So if you can put them in that Q&A box, I'll be keeping an eye on it. But with that, let's just kind of dive in. So my goal for you by the end of this presentation is to kind of have this high-level overview of what withdrawal is, specifically with some of these different substance use disorders. I want you to be able to describe how withdrawal occurs in the body and really be able to identify those life-threatening symptoms that happens with various withdrawal processes. And then be able to explain what that typical withdrawal syndrome or symptoms look like in alcohol, opioids, stimulants, cannabis, and benzodiazepines. So lots of information. We'll go ahead and dive right in by setting the scene. Withdrawal is pretty common. There's not a lot of statistics very specific to withdrawal, but we can get an idea of what our patients are experiencing and how often with some of these different stats. So about half of our patients who have an alcohol use disorder do experience some form of alcohol withdrawal. Doesn't mean they're experiencing fatal alcohol withdrawal by any means, but there is some form of withdrawal syndrome when they do decrease or stop their alcohol use. There has been shown that about 10% of our patients who abuse benzodiazepines, so using them outside of how they are prescribed, do report withdrawal syndromes. However, I would expect this to be a little bit higher if they are mixing with other substances, or even in our patients who are prescribed these substances for long periods of time. It has been shown that 47% of patients who regularly use cannabis do experience some form of cannabis withdrawal syndrome. which I think this information is a little bit newer. I don't think people saw it as prevalent with cannabis as with other substances, but we are learning, just like any other drug we put into our bodies, there is that potential for a development of tolerance and the development of withdrawal syndromes. And then lastly, most of our patients who are chronically using and dependent on opioids and or stimulants will experience some form of withdrawal when they discontinue that drug or decrease significantly their use of that drug. So a lot of our patients are experiencing this. So my goal is to help you understand what is happening and why it is happening. So first and foremost, what is withdrawal? What is our definition? Withdrawal is defined as this physiological response to a sudden stopping or slowing of a use of a substance that the body has become dependent on. This can include a variety of different symptoms. It is very patient dependent and very unique to how much they've been using and for how long they've been using, but it can include different physical, mental, and emotional symptoms for all the substances we're going to describe today. These different withdrawal syndromes can be really painful, and for some of them, they can be life-threatening, depending on how long they're lasting or what the withdrawal syndrome is. So there is need for different medical interventions in these different scenarios. I do want to note that withdrawal is not exclusive to a person who is addicted, who has a substance use disorder, or who are using these medications or substances inappropriately. This can happen in someone who is using their medications exactly as prescribed. Our bodies are really good at adapting. And when they're adapting to different substances, even prescription medications, that can include the process of physical dependence on that substance, a development of tolerance, and eventually a withdrawal syndrome when that substance is taken away. So I hope that helps remove the stigma of what withdrawal is so that we can get all of our patients the help they need when and if that time comes. So very, very high level, what is the basis for withdrawal? Well, I mentioned our bodies are really good at adapting. So really the baseline understanding of withdrawal in general is homeostasis. So this is where our body attempts to maintain some level of homeostasis no matter what we put into it. So when we're consistently giving it a substance that is going to alter our physiologic processes, our body's going to try and counteract that. So it's going to try and get back to baseline as much as possible whenever we are introducing it to these substances. So once we remove those substances, it can cause this residual kind of counteracting to stay a little bit longer, having us experience some of those negative or undesirable withdrawal symptoms. And so within these different substances, there can be chronic stimulation of certain receptors. There can be chronic stimulation of some of these body processes. And a lot of that has to do with our neurotransmitters in drugs. We know that addictive substances work in the brain, and we know that they can alter our brain function and chemistry the longer that we use them. So when we are getting off of some of these substances, it's only natural that our brain's trying to kind of go back to its baseline. So this can result in a variety of symptoms because of that differing in neurotransmitter production than it was before. But we'll kind of see this diagram over and over again. I tried to simplify it and use it in these different withdrawal syndromes so we can see what is off balance in the body to hopefully try to remember it a little bit longer than just when this presentation is over. So for any form of withdrawal, there are different stages to it, and there are some average timelines to when withdrawal starts, peaks, and lasts. But like I said, this can be very different based off of our patients, what their body makeup is, what their genetic components are, but also what substance they're on, how long they were taking it, and what type of doses they were taking it at. But as a general rule of thumb, there is this first stage of withdrawal. It's called the acute withdrawal period. And this is where we start to experience symptoms. They become more intense and it can last for a couple of days, for some substances, even a couple weeks. But then we get pushed into our protracted withdrawal syndrome. period. And this is when our symptoms are really at their worst. So they really start to peak, they become more consistent, and this is where the withdrawal process kind of becomes all-consuming and it's most painful. However, this is also when we kind of go to the other side of that hump. We start to experience a little decrease in their severity, and we start to kind of see that light at the end of the tunnel at the halfway point during that protracted withdrawal period. After our protracted period, we do move into that prolonged withdrawal period, and this is where it really looks different for different patients. Some of these symptoms can last for a really long time, especially with our stimulants, sometimes our cannabis, and other drugs as well, but they can last months to even years. And we do note that you can still experience cravings at any point in our stages of withdrawal. So remember how I mentioned during the process of using substances, especially within the process of addiction, we start to kind of rewire our brain to become dependent on these drugs. And so it can take a while to kind of get our brain back to baseline, which it can do, but it does take time. So in that rewiring of our brain, we started to see these substances as a need. We no longer want them, we need them for our survival, right? And so as we're experiencing really painful withdrawal symptoms, our brain is constantly being reminded that there is a fix to this, right? If we just go back to using that substance, we can be feeling better physically, mentally, and with our cravings. So withdrawal is a really vulnerable point for our patients where they can begin to use their substances again. And so a lot of support is needed within these different periods of withdrawal. And I found this infographic online. I thought it was really helpful just to get a general picture on when withdrawal starts, when those symptoms peak, and the total duration of those symptoms with these different substances. Again, these are averages. So if you have a patient who's been using benzodiazepines and it starts in under a day, that's okay. That is still normal. This is just an average over all the patients who are experiencing withdrawal with any of these symptoms. But you see benzodiazepines, kind of like, for example, start within 1 to 4 days is when those withdrawal symptoms start. They tend to peak around 2 weeks, and those long-lasting symptoms can last between months and years, depending on what they were using. So I hope to find this as a good reference moving forward on just when we can expect some of these withdrawal syndromes to peak and last. So moving on to our second objective, what does life-threatening withdrawal look like? I get asked a lot, especially during Narcan trainings, if withdrawal is life-threatening, and does that make it dangerous to reverse an overdose or to respond to an overdose in an emergency situation? So I thought I would just give some really clear guidance on that during this presentation, since I do get that question several times in Narcan training. There are deadly withdrawal syndromes. Most notably, alcohol and benzodiazepine withdrawal do have some very serious life-threatening symptoms that can emerge during withdrawal. With alcohol, it is most associated with alcohol withdrawal delirium, or previously known as delirium tremens, or DT. And if unmanaged, it can result in seizures that are life-threatening and can lead to death. It is to be noted, though, that this is not in every patient. It is in less than 5% of our withdrawal patients. But when we start to see some of these more severe alcohol withdrawal symptoms, then we need to get them connected to care pretty quickly so that we can decrease the harmful effects of our alcohol withdrawal delirium. Benzodiazepines are another one that can result in some life-threatening seizures. You have a higher chance of this happening when we have been using high doses of benzodiazepines for really long periods of time. So that's where we have the highest risk. We also have the highest risk when we are very quickly reversing that benzodiazepine activity within the body. So we see this a lot less likely when we are letting the drug complete its entire half-life and exit the body when it is metabolized and excreted in natural ways. when we are using reversal agents like flumazenil and very quickly reversing that benzodiazepine activity, that's where we also see an increase in some of those more serious seizures and life-threatening withdrawal syndromes. I do see a question in the chat, or I did see a question in the chat asking what are different types of benzodiazepines. Alicia, we will get to that, and I do have a slide that is available that lists out the names of the different benzodiazepines. So we'll get there in just a couple seconds. I'll put you on pause. I'm sorry, I put you on pause. But one thing I do want to note is that other withdrawal syndromes are rarely resulting in death, very, very, very rarely. So that includes opioid withdrawal syndromes, cannabis withdrawal syndromes, stimulant withdrawal syndromes. They can have complications, and just because they rarely result in death doesn't mean they never result in death. And the most common serious side effect of those withdrawal syndromes tends to be dehydration. So any prolonged situation where the body is deprived of its necessary, mostly water and those electrolytes, is where we can see our most dangerous withdrawal syndrome outcomes. And so if we do have prolonged dehydration in those syndromes that are really high in vomiting or diarrhea, then we really want to connect them to acute services to kind of mitigate some of those adverse events. So all in all, it is safe to reverse an opioid overdose. That quick and acute reversal of the opioid activity is not harmful to that patient. We do want to be mindful and connect them to care if they are going to be continuing on with that withdrawal syndrome, right? We want to make sure they're not getting dehydrated, they're getting the medications and the support they need to kind of make it through that, that withdrawal timeline, even through some of that acute and prolonged withdrawal. But yes, it is safe to reverse an opioid overdose, and I just want to keep reiterating that so we keep reversing them. Okay, so now we're going to get into these specific substances and kind of get a better picture of what they look like individually. Alcohol is definitely still one of our most abused substances within the United States. The NIAAA, or National Institute on Alcohol Abuse and Alcoholism, is seeing that this is the most commonly abused substance in the United States, with over 75% of individuals aged 12 and older reporting some form of lifetime consumption. And so we do see a lot of complications through alcohol use, but also through alcohol withdrawal. So how does alcohol work? Alcohol is a depressant. So it is a depressant in our bodies. Doesn't mean it makes you feel depressed necessarily. It just means that it's going to be slowing down or depressing some of our body systems. And it does that by stimulating the receptors on the GABA processes. So we see in this picture our cute little GABA receptor and all the different elements that can work on it, including barbiturates, benzodiazepines, alcohols, and neurosteroids. So how that works is, initially, when you stimulate and increase GABA within the body, we experience these really sedating effects. So when we're using alcohol sporadically with no real consistency, it can result in sedation. So that means that when someone is drinking sporadically, they might feel a decrease in some of these CNS processes like lower blood pressure or lower heart rate, or even sleepiness when they're starting to consume alcohol or when they consume large amounts of alcohol. And so that's where we kind of get this trope, or this kind of ism that, oh, I've had this really hard day at work. My blood pressure is really high. I just need a glass of wine. It'll help calm me down. This is kind of the mechanism behind how that alcohol kind of helps calm you down, right? However, this does start to change when we consume alcohol on a very regular basis and our body starts to anticipate it. So when we start to consume alcohol chronically, it starts to throw off that balance within GABA, and our body tries to regulate it, right? So glutamate, which is an excitatory neurotransmitter, starts to get really increased to counteract some of those depressant activities of alcohol. And it does this in an attempt to regain that homeostasis. So when someone who drinks regularly stops drinking very quickly or really reduces how much alcohol they are drinking, our bodies already trying to compensate. It doesn't really know that we're going to decrease or stop our use. So those compensatory mechanisms, like that increase in glutamate, is still present even when the alcohol is not. So that really starts to provide some negative symptoms in our body. And that's why we feel some of those withdrawal symptoms, especially some of those very early and initial withdrawal symptoms. And so this is what it looks like in that kind of callback to our homeostasis image. We initially dump alcohol within the body and we don't have enough glutamate or excitatory neurons in our body or neurotransmitters in our body to counteract it. But our body catches up, it adapts, and it starts to increase those excitatory transmitters, increase their production and increase their activity so that we're kind of at a baseline. But when we take that alcohol away, we still have a lot of glutamate in our bodies. So a lot of times when you decrease or stop your alcohol use, you might experience the physical symptoms of anxiety in particular. So a real spike in blood pressure, a real spike in heart rate, a real spike in those anxious thoughts or agitation. And that's because our body's kind of hyped up with all of this compensatory neurotransmitter production, right? And so this is where we start to see that withdrawal. Alcohol withdrawal syndrome is a unique syndrome because it has something called kindling or sensitization that we don't really see in other withdrawal syndromes. This is where when we have consecutive withdrawal experiences, so if you were trying to decrease or stop your alcohol use multiple times in different instances, then you can experience a more severe withdrawal syndrome as time goes on. So the more the body gets used to that withdrawal syndrome, the more severe you can see those symptoms at a later withdrawal experience. And so this can increase our risk of seizures in some of our patients who have had withdrawal experiences in the past that have become increasingly worse. So I always like to ask my patients if they've ever experienced withdrawal before and what it was like for them, or how many times they've experienced withdrawal when they've been trying to quit alcohol. And this is due to the fact that over time, it does lower your seizure threshold. And so repeated episodes of alcohol abstinence can increase your severity in that withdrawal syndrome. So unique to alcohol, but definitely something to be aware of. So when do we see alcohol withdrawal? It's pretty unpredictable and severity can vary, but we can see the highest risk with our patients who have risky drinking behavior. So this is really binge drinking. So when we're seeing binge drinking episodes, even if they're just once a week, once a month, if they're drinking large amounts of alcohol in those sittings, we can see withdrawal after prolonged abstinence. Also, if we see really consistent alcohol use, specifically an alcohol use disorder. We tend to see in alcohol use disorder high quantities of alcohol being consumed and for very consistent and regular periods of time. So we can usually see an increased risk of alcohol withdrawal. Doesn't guarantee it, but it does increase our risk. So those are the two groups that we can predict a little bit more some of those withdrawal syndromes. So what are some of those withdrawal symptoms? These are our less severe withdrawal symptoms that can start within a couple hours since your last drink and can peak around 72 hours. This includes tremors, mostly in our hands, kind of not being able to keep our hands steady or still. Really differing sleep patterns, most commonly with insomnia. So they're not able to fall asleep, but it can also mean they're not able to stay asleep. And so really poor sleep can make withdrawal in and of itself a lot worse, a lot less comfortable. We can also see in these patients sweating, high blood pressure, high heart rate, and then mood disturbances like agitation, anxiety, and depression. And so those are all some of the less severe symptoms of alcohol withdrawal. Some of our more severe symptoms. So anytime we start to see these more severe symptoms, this is where we really want to start being intentional about connecting them to care. So anytime my patients report any form of hallucination, including auditory, so they're hearing things that aren't there, visual, they're seeing things that aren't there, or tactile, they're feeling things that aren't there, kind of feeling those bugs crawling up their skin or feeling pricks or pokes. then I want to connect them to acute withdrawal services. These are rare. Less than 2% of our patients are going to experience these, and they may resolve themselves in 72 hours. It just increases the risk that something else is going to happen too, right? So once I see those severe symptoms, I usually refer them out. Other complications of alcohol withdrawal is Wernicke's encephalopathy. This is essentially due to a B12 deficiency or a thiamine deficiency. And so this looks like a lot of confusion. And so encephalopathy is kind of characterized by this type of infusion, but different than other types of encephalopathy is once we do replace that thiamine and we do kind of help support this person within their abstinence, it does resolve. So that is a good differentiation. We also can see, like we mentioned, withdrawal seizures. And so these tend to happen within 8 hours to 48 hours after alcohol cessation. And so we do typically treat these with benzodiazepines and closely monitor them to make sure that we do not have repeated or related seizures afterwards. We did also mention alcohol with withdrawal delirium, or what was called delirium tremens, or DT. So this is going to be our life-threatening symptoms of alcohol withdrawal. So that can happen 3 to 8 days after cessation or reduction. And so it's kind of a longer time period. So we want to make sure they're supported in that entire time frame to make sure that we see the least amount of harm within the withdrawal process. So this is kind of the timeline to look out for, but can vary patient to patient. So you see a question in the chat: what happens when those symptoms of feeling, hearing things last more than 72 hours? Where do you refer the patient at that point? I definitely refer them to an inpatient withdrawal facility. We do have a few around Spokane. It kind of depends on where you're at. Other good resources are going to be, I know Addiction Help Finder is going to be a really good resource to find the specific inpatient withdrawal facilities, but I prefer inpatient at that point so that they're monitored continuously and they're able to receive the medications they need to help support them through those hallucinations, whatever they might be, auditory, visual, tactile, and just so that we're aware that it may progress past that. All right, moving on to benzodiazepine withdrawal. The process of benzodiazepines is similar to alcohol. It can be a little bit different, but it's going to work on those same receptors. So it is also a CNS depressant. And in order to counteract that, our body is going to upregulate our excitatory neurotransmitters, just like we saw in alcohol. So when I say benzodiazepines, these are the different types of benzodiazepines that we most commonly see. And so this is looking back at Alicia's questions that we had at the beginning of the presentation. But we have our short-acting or really short-acting benzodiazepines like triazolam. We have our immediate acting, so they're a little longer acting than our short-acting. But we have lorazepam or Ativan and alprazolam or Xanax. And then our longer acting benzodiazepine are going to be our diazepam and our clonazepam or Klonopin. And so these are our different types. And all of our benzodiazepines are going to be central nervous system depressants. However, they may work just slightly different, which is why we have so many. And they do tend to target certain symptoms. So for example, that triazolam may be a little bit more targeted at some of our anxiety symptoms, right? Some of those sleep. We do have hypnotic benzodiazepines prescribed for insomnia, also like triazolam. We have our more anxiety-based benzodiazepines like alprazolam and lorazepam. So we do see that for acute treatment of some of our panic attacks and severe anxiety. And then we do also have benzodiazepines like Valium or diazepam that are anxiolytics as well, treating some of those anxious type responses in the body. And then others are more focused on anticonvulsant or seizure activity. So while they all can work slightly different, they're all going to be in the same class and kind of have the same withdrawal syndromes after prolonged use. And we did mention in previously that benzodiazepines can be life-threatening. Benzodiazepine withdrawal can be life-threatening. However, like I mentioned before too, this is very patient dependent. So how long someone has been using them is a real big factor, right? So if you've only been using benzodiazepines sporadically for a couple weeks, your risk is very, very different than someone who has been on these substances for years or longer. And that includes abuse and prescribed benzodiazepines too. Your risk for withdrawal for prescribed benzodiazepine can also increase for patients who have been chronically using them for years and years and years, which is not uncommon. In the late 90s, early 2000s, we still prescribed these a lot for a lot of different things to help people fall asleep, to help people through mourning or bereavement, and they just kind of never got taken off of them, to help people with panic attacks or anxiety. So we do have a lot of patients chronically on benzodiazepines still that might be at risk of withdrawal. It also depends how much they've been using. So how big of a dose and how potent of a dose they've been using, what type of benzodiazepine is typically used, right? So some of our shorter acting might have an onset of withdrawal sooner than our longer acting. Underlying physical conditions, and then if they're using it with any other substances. So specifically if they're mixing with like other CNS depressants, like alcohol that also work on the same receptors, it can really enhance some of those withdrawal symptoms that you can experience from benzodiazepines or alcohol. And here are some of those symptoms. So benzodiazepine withdrawal is not as common, right? We saw that about 10% of our patients who are abusing benzodiazepines might experience it. It might just be that they're experiencing some pretty benign withdrawal symptoms as well. So nausea, panic attacks, tremors, anxiety, agitation, sweating, headaches, and twitching, heart palpitations, muscle pain. Short-term memory loss is a big one, especially for really chronic users of benzodiazepines. Also kind of describing this brain fog of just not really being there or able to concentrate is another withdrawal symptom that we see after really long periods of benzodiazepine use. There also can be severe depression, including suicidal ideation, mood swings, and then as we mentioned, in really severe cases, those seizures. And so these are all things to keep an eye on. So our withdrawal timeline depends on what was being used. So in our graph where we have our shorter acting benzodiazepines like Xanax or triazolam, that might start withdrawal symptoms around 10 hours after use. For some of our longer acting benzodiazepines, it can begin 24 plus hours after their last use. And how long this withdrawal lasts is very patient dependent. A lot of these more neurological symptoms might last a long period of time. So in our withdrawal timeline, we saw that benzodiazepine withdrawal can last months to years for some patients. And that really can include that short-term memory loss, the anxiety, and the brain fog after the physical symptoms start to resolve. So while a lot of these really prolonged withdrawal symptoms are only in a small percentage of patients, for those patients, it's pretty noteworthy in their day-to-day lives. All right, so now chugging along to keep us on track, we're going to look at opioid withdrawal. Opioid withdrawal is a little bit more complex. So the cause and the process of opioid withdrawal is more complex because it does affect more receptors and more body systems. So for the sake of time, I'm going to be going over just a really general overview, a really higher level overview of opioid withdrawal that hopefully gives us a basic understanding to help our patients a little bit better. But studies from animal models have shown that symptoms of opioid withdrawal are really closely related to our cyclic AMP, or kind of where you see it on here, it looks like it's written out as CAMP. And so when we're decreasing our cyclic AMP with opioid use, that really starts to affect how our cells are working in the body, right? And it affects a lot of our perception, like our perception of pain, which is why we use opioids. But long-term, our body starts to regain that homeostasis, so it can really affect how our cells are working in our bodies. And so when we do have opioids in the body and they are decreasing that cyclic AMP, it can result in a super activization of these cells, or this hyperpolarization. So we know that opioid agonists are reducing cyclic AMP, increasing that potassium channels in our cells, hyperpolarizing the cell, which eventually leads to some of our decreased neurotransmitter release, resulting in that really sedating, euphoric, and decreased perception of pain within our patients. However, when we do see that for long periods of time, our body starts to try to regain homeostasis by increasing our excitatory neurotransmitters, similar to alcohol and benzodiazepines, right? So notably glutamine is going to be one of those excitatory neurotransmitters that our body is using to increase our body systems when they're being depressed by medications like opioids. Another unique thing about chronic opioid use is that our body can upregulate our opioid receptors. So when we are flooding our body with opioids and unnatural opioid levels, our body's going to create more receptors to try and capture as many opioids as they can and try to see the most result that they can from this medication. So when we stop or decrease use, we not only have this increase in excitatory neurotransmitters, we also just have an increase in the number of opioid receptors available to bind to opioids. So this might contribute to some of our feelings of depression or agitation or anxiety when we get off of long-term opioid use. So I do see a question in the chat from Amy. I have a difficult time getting individuals into detox when they are using benzodiazepines, especially along with opioids. Any advice on how to help them? I don't think I have specific advice. This is a really tough question to answer because when you have two addictive processes at the same time, it can just be harder because your brain is rewired to kind of believe that you need these medications, right? But also you're experiencing withdrawal from both opioids and benzodiazepines. So it might just be that repeated exposure that these options are available, and education as to what treatment looks like. I think people are really afraid of withdrawal, and it is the number one reason why patients don't seek out treatment when they're ready to stop some of these substances. So I try my hardest to explain what drugs and options we have available and how they work to decrease the severity of our withdrawal symptoms. And sometimes that can bridge the gap enough to decrease their fear and anxiety of this new process and this kind of fear of the unknown to help get them at least at a starting place of withdrawal treatment. But it can be really hard with both of those substances in the body. And so this is what it looks like with opioids and homeostasis. I tried to put it in that same format. Again, this is really high level, but it's where our body is trying to compensate for the chronic opioid exposure. So with short-term sporadic use of opioids, it is decreasing that cyclic AMP, again, causing more of those depressed body systems. So drowsiness, slowed respiration, low blood pressure, all of that is associated with the opioid use. But when our bodies are trying to kind of counteract that and maintain that homeostasis, we're trying to upregulate those other excitatory neurotransmitters and upregulate that cyclic AMP to get a better response over time. So that helps level out the neurotransmitter activity to at least some degree. However, when we stop those opioids really significantly and really abruptly, then we can see those excitatory neurotransmitters at really high levels, right? Dramatically above normal levels because they've been trying to kind of dampen that opioid response. So in this state, specifically norepinephrine is released, and it's responsible for a lot of those really acute and first present withdrawal symptoms like the jitters, the anxiety, the muscle cramps, diarrhea, things like that within our body. And so again, if we do have long-term diarrhea, long-term vomiting. We want to make sure to get our patients connected to care so that we're decreasing the risk from that dehydration. Another unique thing about opioids, since we have a very readily available antidote or reversal agent to opioid activity, is we have two different forms of withdrawal. And this can kind of go back to what Amy was talking about too, of just patients being really, really nervous about withdrawal. Because with opioids as well, you can have withdrawal from decreased use or just sudden abstinence, but we can also have what is called precipitated withdrawal. And this is where it is caused by reversing the opioid activity by healthcare providers or someone else who's reversing it within their bodies. So if they're going to be using Narcan or nalmefene or even drugs like naltrexone is going to completely reverse all that opioid activity and can start precipitated withdrawal in that patient, which is it's still very painful. It's still the process of withdrawal, right? And so this can be another reason why patients really shy away from initiating treatment. Suboxone can cause this too, especially with some of our more potent opioids. It can precipitate withdrawal. So really explaining what options we have to help bridge that gap, especially in that really acute time period of withdrawal, because it is scary. Nobody really wants to go through that, and it is pretty painful. And our opioid receptors are responsible for a lot, right? I kind of mentioned this in the beginning that it complicates the withdrawal process or the withdrawal syndrome because our opioid receptors are involved in our response to a lot of hormones, our perception of taste, vision, smell, perception of pain, our gut mobility, our thirst, our mood stabilization. So when we are going through withdrawal, we can see all of those different body systems affected. And so it can be a pretty all-consuming process, which again, it's just really painful. And it's painful to go through and it's pretty difficult. And so we do see obviously a spike in cravings during this time because our bodies want it to stop. Our bodies want to experience relief. So this is where some of our pharmaceutical medications can be helpful if our patients are willing to take them. So methadone can decrease some of those withdrawal symptoms and cravings. And then once they are ready, Suboxone can decrease or bridge past that acute withdrawal and can decrease our cravings from there as well. So what does withdrawal look like after abstaining from opioids? Wide variety of how this looks. It is very uncomfortable. However, it is to be noted that fatalities are rare. So withdrawal from different stimulants or opioids, they don't typically result in death as long as we are making sure that they are hydrated. But it can look like watery eyes, persistent sneezing, goosebumps or chills on the body, muscle and bone pain, diarrhea, high blood pressure, poor temperature regulation, typically resulting in overheating. A lot of yawning, nausea, vomiting, pupils dilating, light sensitivity, increased heart rate, sweating, and then those mood disturbances like anxiety, agitation, or depression. I also like to keep in mind that our patients started using these substances for one reason or another, right? Sometimes it is to self-medicate for something that was causing them distress. So if we have patients who are using opioids or benzodiazepines or even fentanyl or alcohol to suppress some of that anxiety or PTSD, you might also expect a spike in some of those initial processes, right? Because their one coping mechanism of dealing with that trauma or PTSD is then taken away, and not all of them have the tools, especially if they're not in an inpatient treatment setting, learning the tools to help cope or deal with some of those traumas or anxieties. So that might also be another reason why patients kind of shy away when they don't know what supports they're going to have for these physical symptoms, but also for some of these mental or mood symptoms as well. And I did want to talk quickly just about fentanyl withdrawal because it is a little bit different and we've seen it act a little bit differently within the body. Fentanyl is a unique opioid that we've been seeing a lot of, right? So this illicitly manufactured fentanyl is typically made in powder or tablet form, and it has a really quick onset of action, When a patient smokes it, it can be active within 2 to 5 minutes within the body, but it exits the body really quickly. So it's only available for a short amount of time, averaging around 2 to 4 hours in the body. So it's really increasing the frequency or consistency that somebody is needing to take the medication to avoid withdrawal. It's a very potent opioid. So it is very potent, which means when we take it away, it can result in worse withdrawal because our body is used to this really high level of opioids being present at these receptors, right? Right now, unfortunately, fentanyl is still very available, so there is an increased access to it. So this can also increase our risk of becoming addicted to it, because if it's cheap and available, you're going to keep taking more and increase your tolerance over time, because just like any other opioid, tolerance does develop. So with our patients, I did link a study at the end of this presentation that describes withdrawal being more severe in patients with fentanyl use. And it was a qualitative study where they're kind of having patients describe their experience with other opioids, like prescription opioids like oxycodone or even heroin, and how withdrawal felt with those opioids, and then how it feels with fentanyl. And all of these patients within this qualitative study really described fentanyl withdrawal as worse than these other opioids. So this can be another reason why patients really kind of shy away from treatment, because they don't want to feel that way. They don't want to experience that pain or painful process. Patients chronically using illicitly manufactured fentanyl also have reported expanded timelines for precipitated withdrawal. Fentanyl kind of hangs in our bodies for a long time. It does have a really high protein binding in the body when it's starting to get excreted, which just means that it might show up in our urine longer than other opioids after abstinence. So it can cause a little bit more variable withdrawal timelines based off of how our body is metabolizing and excreting this drug. But what I want to reiterate is that treatment options are still available, and we still can medically manage fentanyl withdrawal just like any other opioid withdrawal. It just might take a little bit different practices, different initiations on therapies, but being able to explain to our patients that it is there and it is going to help with the physical and mental withdrawal symptoms can be helpful in getting them into treatment. All right, you guys are doing awesome powering through all of these. Next, we're going to be looking at stimulant withdrawal. Stimulant withdrawal is a broad term. So the most common stimulant we see is caffeine. I will not be talking about caffeine withdrawal today, but we are going to be focusing more on methamphetamine and cocaine, since that is typically what we see patients have more severe withdrawal syndromes from, and what we tend to see more patients referred to treatment for. So how do stimulants act in the body? This is an example of how amphetamines work in the body, but the general mechanism of all stimulants revolves around increasing our catecholamine levels and increasing the agonistic activity at our adrenergic receptors. So what does that mean? That means that this is stimulating our body processes. So different from our opioids or our alcohol or our benzodiazepines, which were depressants, these are revving everything up. So in increasing our activity at our adrenergic receptors, we're seeing a spike in all of our body processes. And so we are seeing our body have higher temperatures, higher heart rate, higher blood pressures, higher focus, higher, all of that, less sleep. So we're really stimulated, which is why we call them stimulants. So anytime we have central nervous system stimulants like cocaine or amphetamine, it can also produce withdrawal symptoms. Withdrawal symptoms with stimulants, similar to opioids, very rarely cause death, right? And so it's going to be these prolonged syndromes of withdrawal that are going to be a little bit more worrisome for our patients, but they are not life-threatening immediately. Oftentimes, when someone starts experiencing withdrawal symptoms from stimulants, it is going to be very focused on those depressive symptoms. So because stimulants really work on stimulating our dopamine and our excitatory neurotransmitters like serotonin and norepinephrine, the come down from that can be very, very difficult, and it can last a really long time. And so that very severe depression is what is the most hallmark symptom of stimulant withdrawal. But when we have stimulants introduced into the body, our body is going to try and counteract that with our monoamines. And so when we remove our stimulants pretty markedly from our body, our monoamines activity is going to decrease. Because our bodies do adapt to what we're putting in it, if we are constantly giving it the excitatory neurotransmitters like serotonin, dopamine, and norepinephrine, our body is not going to waste the time or energy trying to remake it and replenish our stores consistently. So when we chronically use stimulants, it is going to deplete these stores, and it is going to, in the moment, flood our body with these feel-good chemicals. But when we are withdrawing or coming down from these different substances, we're going to feel a real marked decrease in that monoamine activity, which really focuses on those depressive symptoms. This can also look like other processes like excessive sleep, a lot of hunger, not really feeling oriented, or that kind of dysphoria, or really kind of severe psychomotor suppression. And so recovery can be really slow for these symptoms, and it doesn't help that we don't have a lot of medications that are really good at treating stimulant withdrawal or stimulant recovery. So some of those symptoms that I mentioned are here on these slides, but I did put depression, including suicidal ideation, up at the top because that is going to be our most marked symptom of any stimulant withdrawal, including methamphetamine, cocaine, or even other kind of lower level stimulants like MDMA or ecstasy. They're all going to have that depression for long periods of time after abstinence. You also can experience low energy, weight gain, dehydration, chills, goosebumps, insomnia, and or other, like too much sleep. Brain fog is oftentimes described, loss of pleasure or paranoia. So it can take a really long time to get back to that stable state of doing things and feeling good about it, or feeling pleasure in it, right? It can take a while to kind of get out of that paranoia, and it can outlast our abstinence. So even if they've been abstinent for several weeks, they might still feel some of these more psychomotor symptoms. The severity of withdrawal syndromes in stimulants is also related to the frequency of use. And so we do just need to keep that in mind, what they were using, how long they were using it, and at what frequency. Some of our patients take stimulants every single day. Others take it every 3 to 5 days. So just knowing that helps us understand what potentially could happen within their withdrawal timeline. But it's not always a guarantee, right? Just something to give us a little bit more educated of a guess. The timeline for stimulant withdrawal can vary, but I do have averages for a cocaine, ecstasy or MDMA, and methamphetamine. Like I mentioned, protracted methamphetamine or other stimulant withdrawal periods can last a really long time. So we do need to make sure we have those supports for our patients in place. So we do have a question in the Q&A. Would the withdrawal symptoms be the same regardless of the way they are taking the stimulant, IV versus inhaling? Not to my knowledge. So because it's more on a cellular level, that if they've been putting this drug in their body, either IV or smoking, both have really fast onset of actions, then they might have different triggers once they are in recovery, but the symptoms of withdrawal are typically going to be the same. All right, to make sure we do leave time for questions, we're going to get into our last, I was going to say our third. No, we've gone through like 5. We're going to go into our last withdrawal syndrome, and that is cannabis withdrawal syndrome. Regardless of how people use marijuana, if it's legal or if it's not legal, kind of like alcohol, they still can develop withdrawal and tolerance or dependency on cannabis, especially if they've been using it for long periods of time. So there was a study done showing that individuals who began using marijuana before age 18 are 4 to 7 times more likely than adults to develop marijuana use disorder, which can increase your likelihood of experiencing withdrawal from marijuana or cannabis. And I don't know, when I was in pharmacy school years ago, this was when a lot of states were still trying to get cannabis legalized or marijuana legalized. And so there was a lot of maybe misinformation out there about marijuana, that you can't become addicted to it. There's no withdrawal. It's safer than any other drug out there. But just like any other chemical we're putting into our body's going to try and adapt to it as well. So how does THC and cannabinoids work in the body? They are going to attach to our cannabinoid receptors, which we have a lot. And so specifically cannabinoids in and of themselves affect a lot of different body processes. But essentially, THC mediates this biological effect through binding to our CB1 receptors. And so this is going to play a role on different processes like our cyclic AMP, like we saw with our opioids, and other mechanisms as well. But that's really what's going to cause some of these psychoactive effects of marijuana or THC. It's going to cause really slow body movements, lower temperature regulation, some muscle rigidity, and it can also be the cause of some of our pain control that patients see from THC. However, our body is still going to try and maintain homeostasis with cannabis and cannabinoids. So in this process, long-term use of these different products can start to depress that neurotransmitter release, causing some of these withdrawal syndromes. So studies do also show that when people are using different substances together, it can make withdrawal symptoms worse in certain combinations, right? And so when patients are using tobacco, alcohol, and other substances with marijuana, they might have a higher likelihood of experiencing cannabis withdrawal. However, on the other hand, there was a study that showed patients who are using marijuana in addition to opioids might feel less of a withdrawal response to decreasing their use, so decreasing their cannabis use. So those are just kind of some unique aspects of cannabis withdrawal and how our body tries to maintain homeostasis. Another thing to kind of understand is that as marijuana becomes legalized and our kind of procurement of marijuana and cannabis products tends to be a little bit more refined, we can have really potent types of marijuana, specifically in forms like dabbing, where it's very, very potent THC. We might see a really increased risk of withdrawal syndromes because of how potent that is in our bodies. So if our patients are dabbing or kind of using that wax type of cannabis, then they might have a more severe or more likely chance of experiencing cannabis withdrawal. Very similar to our benzodiazepines and opioids, a lot of people start using THC or cannabis as a response to self-medicate for something. So if you do have someone who is using it for a mood disorder, anxiety, PTSD, anything like that, they may experience withdrawal symptoms related to that initial whatever they took it for, that initial cause, that they might also need support for when they are decreasing their marijuana or THC use. So question in the chat, if a patient is on monthly buprenorphine injections and they miss their monthly dose, can they begin to have withdrawal symptoms within a few days? So with injected buprenorphine, you have to remember this. I might not be exact on the timeline, and I know there are 2 formulations of injectable buprenorphine, so their timelines may be slightly different, but you can start to see withdrawal fairly quickly. I wouldn't say within minutes or hours of missing their dose, but within several days, because those medications on average last between 3 and 4 weeks in the body. And so that's when it starts to leave the body. So it's called a half-life because half the drug is in the body at a certain amount of time, and then it kind of keeps decreasing from there. And it's not always just linear. And so once they've missed their dose, it can be a couple days that they start to see some of those withdrawal symptoms. However, some of those cravings can come a little bit sooner. And since we have less buprenorphine in the body, we might see a risk of overdose at that point if they start to use more potent opioids like fentanyl, heroin, things like that. So buprenorphine injection can result in withdrawal, physical withdrawal, a couple days after. Cravings from not having that buprenorphine injection on time might come a little bit sooner. So what is the marijuana withdrawal symptoms and what is the timeline? Most of those withdrawal symptoms are going to be mood related. So depression, anxiety, agitation, and irritability can really be spiked with marijuana discontinuation. You can also see restlessness, insomnia, appetite changes, specifically decreases in appetite, sleep disturbances, headaches, nausea, vomiting, sweating, and tremors. But timing can really vary. So this is another drug that sticks around in the body because it is fat soluble. Sometimes we can see it last in the body longer, like kind of physically be in the body longer with chronic use. So symptoms typically start 24 to 48 hours after last use, can peak at 2 to 6 weeks, and most will resolve in 3 to 4 weeks. However, that can be very patient dependent. And if they have been a very chronic user of marijuana, daily user for years at a time, this can be kind of drawn out. So having supports for them can be pretty important. Okay, so my goal is to only talk for an hour and leave about 15 minutes for any types of questions. So I'd love to open it up in the Q&A or in the chat for questions that you might have.
As folks are typing out questions, I have one for you. Do you see anything different in youth for withdrawal syndromes with these different substances?
I don't have a lot of experience with youth and how youth experience withdrawal. I could definitely look it up for you and get a little bit more informed, but personally I don't usually treat that population. But if somebody else in our attendees does, I would love for you to kind of put that in the chat on anecdotally what you see in your patients who are not adults.
I'll ask another one here. I'll just keep asking until people start typing up some questions. Oh, here we go. Now it looks like there are questions coming through.
All right, let's see. So what type of supports are available for marijuana withdrawal? So with marijuana withdrawal, I think it's less common to see inpatient treatment centers solely dedicated for marijuana withdrawal. However, I don't think it's out of the question depending on where you're at. But you would basically be treating it symptomatically. So if they are experiencing agitation, mood disturbances, or more psychoactive symptoms, then you're going to treat that with more mood stabilizing medications if you need it. Dehydration, we're going to rehydrate them. And so it's really very specific on what they're experiencing. We're going to treat it as it comes. Claudia asked, how can we prove attendance for this event? Oh, that's not my question. Maybe Megan can answer that one.
Yes, I can answer. Oh, and it looks like Justin did as well. So we have that survey link, which we'll have either Alex or Justin pop into chat again. So you can fill out that survey, make sure to put your name and email address in there. And once the series ends at the end of the month, we'll send you a certificate of attendance.
Awesome. The next question we see in here is, what about nicotine withdrawal? That is an excellent question. We do see a lot of our patients have nicotine addictions, whether it's vaping or cigarette smoking, but nicotine is a stimulant. So it's going to be obviously not as severe as methamphetamine withdrawal, but it is going to have some of those same processes, right? So a lot of that kind of mood destabilization, especially because cigarettes or nicotine is often used to calm somebody down in states of agitation. So that coping mechanism is taken away. So you'll see spikes in agitation, sometimes anxiety and depression, but the body does go back to normal pretty quickly with nicotine. It's just kind of like those cravings as well. I also did forget to mention that this reminds me about anytime we have a patient who is chronically using stimulants, whether it's nicotine or any other stimulant like cocaine or methamphetamine or MDMA or ecstasy, if they have any underlying ADHD that has not been otherwise treated, you will likely, if not certainly, see a spike in complications from ADHD when they discontinue those medications. So that's unique to that neurodivergent population. But since it's treated with stimulants and we are taking the stimulant away, we oftentimes see a lot of different executive dysfunction or unable to kind of make decisions or follow through, or kind of this dysphoric sense of time, which is just common with very uncontrolled ADHD. So that can complicate some of our stimulant withdrawal. Let's see, is there a way for someone who is dependent on opioids to prepare to stop taking opioids? I would say the best preparation you can make when decreasing or stopping any substance, but specifically substances like alcohol, opioids, or amphetamines, is going to have those supports around you and a way to engage that community. Because this is a really a team effort at this point. So engaging someone in treatment and then keeping them in treatment in a disease that is characterized by continued use despite harmful consequences, that can oftentimes make the biggest difference. And then just preparing them for what you might see in these different programs, right? So that they can feel a little bit better going into it. We'll also put my references slide up. This will obviously go out to you with the PDF of the slides, but these are just some really good resources if you want to look a little bit deeper into any of these withdrawal syndromes. And that last website at the bottom, American Addiction Centers, I found had really good patient-friendly language on what's happening in the body and what some of these symptoms look like in kind of like real life. What are your thoughts on natural supplements during the detox process? I think the detox process can certainly be holistic. I would just urge everyone to remember that natural supplements are still drugs. So your body is still going to respond to it just like it would any other drug. So just keeping that in mind, but I do think it can really be helpful as long as it doesn't interact with any other medications in finding a holistic approach to managing somebody's recovery. I think in any scenario that is very worthwhile to look at. Yeah, when I was in pharmacy school, I got to rotate at our poison center in New Mexico, which was such a valuable experience. But something that I learned there is a lot of calls that we got consulting us from the hospital were for natural supplements that caused harm in the body because they were taken in too high of quantities or for too often. So I always took that with me and kind of tried to tell people these are drugs too.
So I have another question. So when I was in school, I also remember hearing that THC or cannabinoids didn't cause addiction. So in your opinion, has the perspective shifted because there's more research or because cannabis legalization is less politicized than it once was?
I think it's both. So one, it's less politicized. I think people were trying to just make the best case possible to get marijuana legalized, which truthfully, it is less harmful than other drugs that we do have legal, right? Alcohol causes a lot of problems and that's legal. But to say that it's harmless and that it will not cause addiction, I think is just misinformation. And now it is easier for people to study it. So we have more information that way, but also it's easier for people to talk about it and use it. So you hear more anecdotal reports from your friends of, oh, I tried to stop my vape last night to go to sleep and I couldn't fall asleep and my heart was racing and I felt so anxious. So I had to take it. Like, this is such a weird thing. And you kind of start this discord of what is withdrawal and could you be experiencing withdrawal and more frequency because more people are just have access to it.
Great answer. Thank you. Okay, so I think this will be the final question, and then we can give folks 5 minutes extra before they transition to the next session. What is one action step you would like our viewers to take today?
That's a really tough question. You saved the hardest for the end. I feel like one action step I would like people to take is just to kind of reflect on what some of our patients are going through. I mean, it's easy for us to see it day in and day out without like feeling it or experiencing it. But to understand, I don't know, maybe a little touch of empathy, right? That this is really, really hard. And just because we've seen some people get through it doesn't mean the next person is going to have the same resiliency or support that our previous clients or patients had. So just as hard as it is, trying to maintain empathy through the withdrawal process by better understanding it.
Perfect. Thank you so much, Dr. Rodin. So everyone will have these slides posted on our website as well as the recording, so you can always go back and review things. Day 1 and day 2 are already posted on the website, so feel free to check those out. And then I'm hoping to get day 3 up by the end of this week or beginning of next. Please continue to ask questions, join our sessions. Our next one is at 10:30, and it is Humanizing Through Connection, where we'll hear from a woman who founded an organization called Fentanyl United Crisis Coalition. She lost her son to a fentanyl overdose. It'll be a very, very powerful session. So I hope that you will all join that at 10:30. We will see you all soon. Thank you again, Dr. Rodin. This was fantastic.
Thank you very much. And thank you for putting this on. We appreciate you all.
All right, see you all soon.